Good afternoon. This is Dr. John Bennett broadcasting from Miami in the morning. Today we have the pleasure of having Roberto Herrera, MD, a neurosurgeon from Buenos Aires. Roberto is a frequent conference goer, and he knows a lot of people around the globe. And he seems to have a progressive practice in neurosurgery, and they seem to be actually leaders in the field of neurosurgery in Latin America. We're glad to have him here today. He's going to talk about uncal herniation, anatomy, pathology, and consequences. And we may have a few members that may join us along the way. Good day, Roberto.
Today is good morning in my country, in Argentina. Here it is 9 in the morning. And good afternoon for the colleagues in Europe and the rest of the world.
Yeah, we rousted Robert out of bed yesterday at 4 in the morning to participate in a conference, and he was nice enough to participate. And okay, Roberto, it's all yours.
I can start?
Yes, yes.
Okay. I press my conference. First, I press my conference and then, okay. Can you see?
Not yet, not yet, no.
Not yet.
Not yet.
Excuse me. Now?
Not yet, not yet. I think you got the wrong screen. That's what you see right there. You see that, right?
Okay.
Yes, you can see it. Yes.
Yes?
Yes.
Okay. Can you see my screen?
Yes, we can.
Okay. I am going to start my conference. Okay, Robert, John?
Yes, yes.
Well, I'm going to talk about uncal herniation, hippocampal uncal herniation. The cranial cavity is divided, is partitioned by the tentorium and the falx cerebri in different compartments. And when a part of the brain is compressed by an extrinsic lesion, the brain is displaced, the brain is herniated from one cranial compartment to another. Here, this is the tentorium, the falx, and this is the different compartments. This is an herniation, brain herniation on MRI and pathological specimen. There are different kinds of brain herniation. And cerebral herniation occurs when the brain shifts across structures within the skull, such as the falx cerebri and tentorium cerebri, as I said. And the foramen magnum too. The trauma is most frequent, most common cause of brain herniation, but there are another cause like as cerebral edema, hematoma, stroke, tumor, infection. I'm going to talk specifically about temporal, transtentorial, or uncal herniation. This is this herniation from the middle fossa in supratentorial compartment to infratentorial compartment. through the free edge of the tentorium. Here you can see the herniation of temporal lobe. This is the brainstem. And uncal herniation represents anterior lateral transtentorial herniation. And is readily identified on CT and MRI. This is the pathological specimens. It is very important to know the anatomy of the cranial base. This is the middle fossa, where the most of the pathologies compress and produce the herniation of the hippocampus. Here you can see the free edge of the tentorium, and this is the third nerve, which results compressed in this kind of herniation. This is the typical roton dissection, and here you can see the tentorial free edge, and it is a sharp meningeal edge that can produce a damage in temporal lobe. Can you hear to me, John?
Yes, I can.
Yes, okay. I go up. This is the anatomy of the hippocampus. Here you can see the temporal lobe. This is the hippocampus, the inner area of temporal lobe, and this is the cerebral peduncle, and this is the third nerve. Here you can see in yellow the hippocampus, and in this picture there are a very important detail. Here you could see this mark is the mark that the free edge of the tentorium produce in the hippocampus. This is in a normal brain. This is the mark of the edge, the free edge of the tentorium. And here you can see the close relation between third nerve and inner area of the hippocampus. This is in yellow. This is the head of the hippocampus, the uncus of hippocampus, and the most anterior area of the temporal lobe here in a roton dissection. And here we see the head of the hippocampus, the body and tail, and this is the uncus of hippocampus. When we open the lateral prolongation of the sphenoidal prolongation of the lateral ventricle, we can see the horn of Hammond horn here in yellow. This is the choroidal plexus, and this is the interior of the ventricle. The vascular anatomy in this area is very rich, it's very important, and we have three vascular pedicles depending each from the middle cerebral artery, posterior cerebral artery, and anterior choroidal artery here. And this is the basal vein here, the cerebral peduncle here, and the choroidal plexus is here. This is the same. Here you can see the hippocampus, the amygdaline area, the fimbria here, and the inner area of the temporal lobe here. Posterior cerebral artery, middle cerebral artery, anterior choroidal artery here. This is the fimbria, the choroidal plexus here. Is an area with very rich vascularization. And this picture shows the way we can see the hippocampus in the MRI. And this is the hippocampus, and this is middle cerebral artery here, posterior cerebral artery here, and choroidal artery here. The three vessels, most important vessels to the brain circulation, brain irrigation in temporal lobe. And this is how we can see in pathological anatomy the herniation of the hippocampus and very important displacement of the midbrain. And here is how we can see it on CT scan. This is the important swelling of temporal lobe. This is the free edge of the tentorium, and this is the area through which we can see the herniation of the hippocampus. Respect the clinic that the herniation, the hippocampal herniation produced, it's very important the relation between this free edge of the tentorium with third nerve. The hippocampus herniated go across the free edge and displace and compress the third nerve, producing the different pupils syndromes with anisocoria, mydriasis, secondary to ipsilateral third nerve palsy. This is the same in Rotom specimen, the third nerve and the free edge of the tentorium here. This is the middle fossa. The patient should be evaluated completely with Glasgow Coma scale, and it is important to examine the behavior, opening response, verbal response, and motor response, of course. And there are Kernohan phenomenon. It is important but in some cases the effect of the mass effect of the lesion displays the midbrain, the brain peduncle, and it is compressed in the other side against the free edge of the tentorium of the other side, and produce an ipsilateral hemiparesia that it is known that a false localizing sign. Which is what are the treatments about to better the condition of the patient? We can talk about the compressive craniectomy. The compressive craniectomy has a long history, and here you can see the first trephination, the first small craniectomies in very old Pisces. But where Kocher and Cushing at the beginning of the 19th, who made the compressive craniectomy to treat elevated ECP, and they practice subtemporal and suboccipital craniectomy. But nowadays, the role of the compressive craniectomy in trauma, brain injury, and in the control of intracranial hypertension remains a matter of debate. It's not clear, and and there are some questions about respect the compressive craniectomy. How we make this? There are different surgical techniques, but it is important. The compressive craniectomy could be unilateral or bilateral, more anterior or more posterior, but mainly 6 or 7 burr holes inside. It's important to preserve the bone in the midline. You can do it with bicoronal incision in bilateral cases or unilateral like this, for example. But it is very important in uncal herniation to decompress the temporal lobe. It is very important that the craniectomy could be done down. It is necessary to remove completely the temporal bone squama to release really the temporal lobe. It is very important to expose, to remove the temporal bone squama and because we can have completely free the temporal lobe. This is the aspect of the craniectomy we prefer to do, with very down here in temporal area. And some examples of the compressive craniectomy: big incisions, exposure of this. Here you can see the inferior area of the temporal lobe, the squama of temporal lobe. This is before to open the dura mater. In this case, it's a bifrontal craniectomy, decompressive craniectomy. And this is the closure of the dura mater with some parts, so with plastic. And there are, we prefer the star sharp to open the dura mater here. This is the big decompressive craniectomy, and the CT scan after relieve the hypertension, intracranial hypertension. This is an example in a big subdural hematoma here with important mass effect on the midline and on the ventricular system. This is the aspect of the after craniectomy. Here, this is the craniectomy, big craniectomy to the bottom of the temporal bone. Some hemorrhagia here. This is the swelling of the brain through the craniectomy. And the compressive craniectomy has complication as infection, CSF fistula, subdural hygromas. It is an important surgery. But now we have this. This is the important work in the many years, in the last several years of my personal friend, Dr. Professor Hipechelian, and he asked himself if the cisternostomy replacing the age-old decompressive hemicraniotomy, and I think it is possible. I really agree with the concept, with all of the concept of Professor Cherian. Respect the CISTERNOSTOMY for traumatic brain injury, for acute traumatic brain injury. And in our country, in Argentina, in Buenos Aires, we are starting to do this technique, this Professor Cherian technique, combine until to now, we are combining the decompressive craniectomy and after remove the bone, we are starting to do the CISTERNOSTOMY with I think this procedure in our hands is necessary to have more experience, but I agree completely, repeat completely with the concepts, respect the direction of the LCR with Dr. Cherian, Professor Cherian. Another important trauma of the temporal lobe, mainly in the hippocampus, occurs during the delivery, mainly in women who deliver a baby for the first time, because there are some narrow canal delivery, and the head of the baby can suffer some grade of injury. This is if a child has experienced a significant lack of oxygen during the course of labor and delivery. There are some instances where the baby is born blue and not breathing. This is the purplish baby with cyanosis baby. And if you have a narrow canal delivery and a bad oxygenation of the baby, we can see uncal herniation and uncal compression of the uncus of the hippocampus against the free edge of the tentorium. Here you can see this in green. You can see the mark of the tentorium produced in the hippocampus. This is in green. This is the area where the free edge of the tentorium contact with the hippocampus, and this is the mark I watched you before. This is the uncal herniation. Repeat, narrow canal of delivery with hypoxia is together can produce important lesion of the in the hippocampus area. This is in human specimen with different grades of compression and lesion, hemorrhagic lesion of the hippocampus. And when the patient grow up, we could see this mesial temporal sclerosis. Here you can see the typical sclerosis in the hippocampus that we treat in many cases secondary to refractory epilepsy. This is very known. It is very known lesion on the hippocampus, and most of them could be produced during the delivery. Nowadays we can take measurements of the volume and compare one and another temporomesial sclerosis. I'm going to show you some cases. For example, this is hippocampal lesion. We decide to remove it. The patient had epilepsy, refractory epilepsy, temporal epilepsy. This we operate with intraoperative MRI. Here we put a mark to prove the complete resection of the hippocampus. And this is the MRI, 3 months post-operative with complete resection of the hippocampus here. And this is the patient 2 years post-op, in very good condition, very good control of your seizures. Temporal lobe tumor can produce uncal herniation too. Here you can see a very important uncal herniation secondary to a brain tumor, temporal lobe tumor. In these cases, here you can see the tumor in this temporal lobe, here a big tumor here. In this case, it is very important to remove the tumor and decompress the brain stem. This is the craniotomy we made. This is the temporal lobe. We resect temporal lobe with the tumor, and it is very important to release the compression on the brain stem. This is the temporal, the middle fossa completely empty here, and with magnification you can see the dura mater of the floor of the middle fossa, the brain stem here, posterior cerebral artery, carotid artery, internal carotid artery, and third nerve here, and the relation between the free edge of the tentorial with the third nerve here. And this is decompressive lobectomy to release uncal herniation and to remove a tumor, of course. Another case, very important tumor, a big tumor here, and you can see very important herniation of the hippocampus with displacement of the third ventricle here. And this is the same patient 5 years post-operative with light hemiparesia and complete resection of this oligodendroglioma. And here the same, you can see middle fossa completely empty, and here the brain stem completely free. Okay. The brain herniation is a long topic, it's a big topic, but the uncal herniation, I think it is very important because we can see a patient coming, walking, and talking, and in a few minutes, half of hour, the patient could be died. I consider that to know something about uncal herniation, it could be important for us. Thank you very much for your attention. Thank you, Dr. Sean. Thank you, Ipe, for your confidence with me, and I hope you can enjoy this brief conference. Thank you very much.
Thank you, Roberto, for an excellent presentation. Well illustrated, well commentated. You know, we have 2 heavyweights here, you and Ipe. Once we get Ipe back to the screen, I'm sure he has lots of comments and questions, and I'm sure he treasures these minutes.
No problem. They will be able to see the conference, the conference later. No problem.
Yeah. No, I'm sure Ipe has a lot to say when you mentioned decompressive craniectomies, and I'm sure he's happy to see that you're incorporating cisternostomy, and since IPE seems to be pretty well known. IPE, are you there? Can you hear me, IPE? Let's see if because I'm sure he'll have some comments on your presentation. But let me ask you one question while we're waiting, Roberto, and this is from a non-neurosurgeon. Is it inevitable that uncal herniation occurs when you have increasing intracranial pressure? Does it always happen, or is that just one of the possible bad outcomes?
Yes, yes, but I think the Professor Cherian works could be the future, could be the good present, and could be the future to resolve the intracranial hypertension in this kind of herniation, brain herniation.
Okay, IPE, I'm sure you have a lot to comment on. Being a cystostomy guy, so could you please unmute and comment, please? Unmute, IPE. Unmute, IPE. Unmute.
Oh, sorry, I was talking all this time, and I was thinking
I'm sure you're chomping at the bit here.
No, can you hear me now?
Yes.
Yes.
Yeah, Roberto, congratulations. First of all, John, first thing is on experience, I do not have even half the experience that Roberto has with respect to skull base, vascular, or trauma. I mean, he comes from a country where a lot of cases are being done, and I have seen his fantastic, he does everything from trauma to microvascular anastomosis, and you know, he has been here for a long number of years. So he is one of the senior people, and I mean, I must say that we are really honored to have him, number one. Number two, when I presented my cysternostomy about 6-7 years back, I remember the kind of criticism that I used to get, and I was very, you know, you could say that I was very pissed off, because I was seeing results in my theater, and when I was telling this to senior people, they were laughing at me. So when I went to St. Louis in 2012 and 2013, I remember seeing Roberto in one of those meetings, and I remember all the people who were encouraging me at that time, because there were very few people to encourage me at that time. There were very few. But I remember his words telling me that this is exactly what we used to do for acute aneurysms. I remember him telling me this. I remember meeting him because I liked him so much. I remember I brought Nepal's alcohol, and I remember calling him down, and I remember going to him and seeing him separately. Do you remember Roberto in Missouri, St. Louis?
Yes, yes, I remember, of course. But John, I can hear in the words appears cards. I can hear well.
Okay. One second. Can you?
Can you hear Roberto or no?
I can hear to you well, but no Ipe. The words appear cards.
Okay. Hello, can you hear me now? Can you hear me now?
Can you hear now, Roberto?
Yes. Could be, yes.
Okay. My internet connection may not be the greatest, but you know, all I was telling is that Roberto has been a huge support for me, and with this kind of experience, with his expertise in surgery, you know. For the young, I'm not saying I'm the younger generation, but I'm definitely one, or at least half a generation younger to Roberto. So, you know, the young generation right now, they are very arrogant, and they get their way. They get their way the way they want it. And there are very few senior neurosurgeons that they respect because they think that they know everything. But let me assure you, Roberto is a person that everybody respects, because the kind of work that he does is amazing. We have seen that, right from Missouri, and I have been hearing very good things about him. And we, in fact, last meeting that we did in 2015 Nepal, I wanted to invite him. He could not come here, but I am hoping to meet up with him sometime, either in Brazil or even in Argentina or in Nepal, and sometime planning to meet up with him. Regarding cysternostomy, you know, it's been over 8-9 years that we've been practicing this thing, and now I am being less radical because, you know, when I started this cysternostomy off, I thought it is a cure to everything and it's going to change everything and it's radical and things. Well, I still believe in that, but you know, I believe that my approach to converting people to cysternostomy is completely wrong because, you know, I just told people who were designed or who were brought up with 100 years of decompressive hemicraniectomy, I told them it is a criminal surgery, you shouldn't do it, and it was wrong completely. And also, I came to understand that cysternostomy is not magic. Cysternostomy has its complications, but anyway, any day I will prefer cysternostomy to decompressive. But even then, I also understood that decompressive could be done by anybody in any center without a microscope. And cysternostomy, for cysternostomy, you need a lot of technical expertise and you need a lot of instruments which not a lot of centers would have. So I understood, you know, the disadvantages of cysternostomy. And the advantages of you know, decompressive. So as Roberto suggested yesterday that I should probably start off evangelizing that you know, you should start off with decompressive hemicraniectomy and then start opening the cisterns and then see the difference. Once you see the difference, then I really don't need to talk to anybody about cysternostomy. They will definitely keep doing it and then, you know, advance it. The only thing, the best thing that we can have is teachers like Roberto or people who are doing aneurysms like Ramesh or Nikolai or Goi in China or Lon in the US or people like that, or Roy Thomas Daniel in Switzerland. All these guys are very senior teachers who are capable of doing any aneurysm, acute aneurysm, and these are the people who should be in forefront, whom I should convince to, and who should see for themselves. These are people whom I cannot, you know, say some bullshit and make them believe. This is impossible. So he understands me because he's a vascular surgeon. Many trauma surgeons will not understand me because they do not even understand. When I go to big trauma meetings, they do not understand me because they just don't understand what is skull base. They don't understand what is vascular. So I feel very frustrated, but these are the kind of people I want with me. These are the teachers who should lead the young generation slowly from decompressive to cysternostomy. So, I mean, I would be very thankful to Roberto again and to you, John, for organizing this.
Okay, it's a pleasure to be with you guys. Roberto, obviously he speaks Spanish. He's from Buenos Aires, but we had a conference last couple of weeks ago, and he brought a bunch of great Argentinian neurosurgeons, and I could see that he's a leader, doing intraoperative CT, intraoperative MRI. I mean, and I'm not a neurosurgeon, but I can see that you're doing. You're on the cutting edge of neurosurgery in Latin America. I can see that.
I am waiting to invite you to HIP to my country because I want they explain this for the young neurosurgeon in my country. We are starting to do the cisternostomy, but as I told combined with craniectomy, decompressive craniectomy at this time. But I agree completely, Hipe, with your concepts about the cisternostomy. I agree, and I congratulate you for this development that I think could be very important in the present and in the future in the trauma treatment. Congratulations for your work.
Thank you very much, Roberto. Thank you
Okay.
very much.
Okay. Okay. This ends this presentation. I thank you very much, Roberto. And our next presentation, I hope you guys can hang around. Yannick Bolio, an intensivist from Montreal, he's made a wonderful platform for remote teaching of surgical procedures, and I hope I know Ike wants to do this with various surgeons, neurosurgeons around the world with cystostomy, and I'm sure, Roberto, you're a teacher. I'm sure you might like this platform, but stick around if you'd like to, and we'll end this broadcast right now. Thank you.